Hello, my name is John Marshall, and I'm Chief of the Division of Hematology and Oncology at Georgetown University, and I'm a GI oncologist. And I'm just delighted to begin these web blogs or web broadcasts around the topic of cancer, GI cancers in specific, but we're going to talk about a lot of different things. In fact, I want to really start with what I think is possibly the most challenging thing that we face as we go forward as medical oncologists today, and that is healthcare reform. You know, no matter which guy gets elected to be president, both are going to have to face the issue of healthcare reform. And for a long time, we in oncology have enjoyed, frankly, pretty protected time. They've left us alone. They have allowed us to give access to patients to drugs, and to antiemetics, and to growth factors, frankly, without lots of data, with not a lot of data to support just what this does for cancer patients. Now, let's face it, the last several years, the last decade or more of cancer therapies has resulted in some major significant advances in the treatment of common malignancies. But we still have miles to go, and as we go forward and as the money tightens, will we be able to sustain this here in the United States? And just what will oncology care look like a few years down the road? I think it's a good place to start really remembering how we got to where we are. Not too many years ago, probably 20, 30 years ago, we started to give intravenous chemotherapy. We started to have some medicines that could work for patients with cancer, and the world of outpatient chemotherapy, outpatient infusion was really born. And on the backs of this, we needed to figure out how to pay for this. And so really what happened, of course, is that physicians said, look, I can't give this without some sort of support. So Medicare agreed to help cover this by allowing us to mark up our chemotherapy and allowing us to charge for the chair time when patients were in getting their chemotherapy and their treatments. And for a long time, that was perfectly okay. That was adequate. You know, oncologists weren't making a lot of money, but it was covering what we needed at the time. Who could have really envisioned the last decade or decade and a half of cancer medicine, when not only were more and more medicines coming out, but you had to keep giving those medicines repeatedly. There were growth factor support, there was antiemetic support, and quite honestly, the paradigm shifted because these medicines were expensive and patients kept coming, to where the more chemotherapy, the more medicines we prescribed, the more money an oncologist and an oncology practice would make. And of course, the last decade has seen that oncology has become one of the most lucrative practices in all of medicine. Doctors were able to build really what I like to think of as palaces to give chemotherapy, and much nicer environments than we ever had before for these cancer patients. And we were racking up a pretty big tab, and again, folks were leaving us alone. And I think one of the things we're going to really have to face as we go forward over the next couple of years is, okay, all of those medicines, all of that money that's being spent, is that balanced by value? Are we getting out of that treatment what we think we're putting in? Is it worth the money that we're spending? I reflect on this a lot. I think about the very expensive medicines we use in colon cancer. And yes, we have moved the bar from a median survival of 1 year to now a median survival of 2 to 3 years, but at the cost of maybe $25,000 to $30,000 a month of our healthcare dollar. And really the hard question for ourselves is, would we actually pay for that ourselves if we had to? Is that worth it to keep putting in that kind of money each month to stay alive? Who could in fact afford it if you had to pay out yourself that kind of money as we go forward? And so I do think we all recognize that that margin on the chemotherapy is going to get smaller. It's going to make it harder and harder to provide a lot of the cancer care we're offering now. Even today in clinic, we're seeing time and again patients not having access to drugs that frankly we'd really like to give them because of the financial barrier. The insurance company won't cover it. We'd like to try it. But the patient can't afford it, and so we don't do it. We do different things depending on what that individual patient can afford. And I think as a drug developer, and as we think forward about new medicines for colon cancer, we really have to worry that our new drugs are only going to work in a subset of patients. We're getting smarter about that. The molecular biology is telling us only certain patients will benefit from certain drugs. And therefore, what's the cost of that drug going to be? Is it going to be a viable economic model to develop drugs for only a small subset of patients? So as we go through a variety of these video blogs, I'm going to bring this back up, this issue of value. Would it pass a healthcare reform test? Would you pay for it yourself? Sort of in closing, I ask you to think about that question. Is there a medicine, a cancer medicine, that you'd pay for yourself, where the value of it is such that it would be worth going to the pharmacy and writing a check for that drug? The one for me, frankly, is Gleevec if I had CML, maybe even if I had GIST. I think 5-FU is probably still a good bargain. But then when we think about some of the other medicines, particularly that we're using in GI tract cancers, would you in fact decide to pay for that if you had to pay for it yourself? Food for thought. I hope it's interesting to think about these things because we're going to look at it hard. We are going to look at a lot of specific data as we go forward. So please come back and we'll talk some more.